Good morning, everyone. This class will be about the vestibular mechanisms of the ear. That is how a person is able to balance the body in presence of different circumstances while moving or while bending. So what is the role of the inner ear vestibular apparatus in balancing mechanism? This class will be dealing with all those aspects. So first of all, the functions. The vestibular sensation, it communicates to the brain the head's orientation and the changes in the head's motion. So there are two things, orientation as well as the motion. So uh, one has to one has not to be aware of what is the orientation. It will be all taken care of by the vestibular apparatus. And while even we are moving, we are able to balance the body. It is all a contribution from the vestibular apparatus. So why this information is important at all? This information is important because the generation of muscle contraction that will reorient the body when something pushes us aside. This will be taken care of by the vestibular spinal reflexes. So the appropriate muscular contraction has to take place to reorient the body, and something has to tell the muscles that now it is time to reorient or bend in some other direction, so that the body is repositioned or reoriented. To move our eyes continuously so that the image stays fixed on our retinas, and that is contributed by the vestibular ocular reflexes. The two important reflexes which you can see here, vestibular spinal reflex and the vestibular ocular reflexes, these two are important uh, letting us do the activity which we are doing uh, in an autonomic way, like without thinking that we have to reorient ourselves. It takes place through the reflex mechanisms which are initiated by the vestibular apparatus. And when this sensation is gone, like this ability is gone, then it can lead to condition called vertigo. That is, the vestibular dysfunction can cause the feeling that the world is uncontrollably moving around, or there is a situation, there is a feeling of vertigo. Everything is moving around because that balancing mechanism is not there. Now, what are the apparatus which are required, the sensors, the machinery which is there, which takes place of the balancing mechanism? Let's have a look. The vestibular portion of the ear has 5 sensory structures. There are 2 otolith organs and there are 3 semicircular canals. The 2 otolith organs are the saccule and the utricle. These, the 2 otolith organs, these detect gravity and the linear head movements. That is, when we are in motion, then our head movements and the bending movements, they are detected by the 2 otolith organs. If we are rotating or if we are in a circular motion, then that information is picked up by the semicircular canals and it is transmitted to the appropriate muscles so that reorientation movements takes place. These structures contain endolymph and they are surrounded by the perilymph. Now we will see how these two apparatus, what they are comprised of and how they work. So you know that the inner ear, there is a membranous labyrinth and there is a bony labyrinth. This membranous labyrinth is positioned inside the bony labyrinth and it has semicircular canals. It has the utricle and the saccule, which maintain the equilibrium. So in this picture, you can see the 3 semicircular canals. This is one canal, this is the other semicircular canal, and this is the third semicircular canal, which you are not able to see properly because of the orientation. These 3 canals, they are positioned at an angle and they are not in the same plane. They are in different planes. I'll show you later. So This is one of that semicircular canal, and these are the two semicircular canals. What other structures you see here? There is a utricle and there is a saccule, the utricle and the saccule. And you can also notice certain structures which are present inside the utricle and the saccule. These are the basically the apparatus which will be helping in detection of the head rotation or orientation. So located inside the utricle and saccule is a small sensory area which is called a macula utriculi and the macula sacculi. So what you see here is the macula utriculi and the macula sacculi. Each macula is covered by a gelatinous layer in which many small calcium carbonate crystals, which are known as statoconia, are embedded. So what you see in this picture, these are the statoconia or the otoliths. Otto word refers to the ear and lith word refers to the stones. So these are the ear stones. They are present in the macula. These are the statoconia, and what you see the gelatinous layer which has these statoconia which are embedded in the layer. What other structures are visible in the picture? These are the hair cells. These are the hair cells which have got hair tufts, and these are the sensory organs. They have nerve supply. The signal transduction which will take place over here will be communicated to the brain via these nerves. So this has a nerve supply. The otoliths increase the specific gravity of the otolith membrane to about twice that of the endolymph. The otolith, this is the structure. This increases the specific gravity of the otolith membrane to about double that of the endolymph. So you can notice that these two structures, they have a difference in the specific gravity of the fluid, and the weight of the statoconia will be able to bend the cilia in the direction of the gravitational pull. So you can, from here you can correlate, this is the otolith organ which is embedded in the gelatinous layer, and these are the hair cells. The hair tufts are projecting in this gelatinous layer, and this will be slightly heavier as compared to the endolymph. So this will be able to bend in a direction of the movement of the head, and this movement will be able to uh, stimulate the hair tufts or the hair cells, and those signals will be taken up by the nerve fibers. Macula has thousands of hair cells which project cilia up into the gelatinous layers, and these cilia, they are the hair tufts which are in relation with the gelatinous layer or the statoconia. When the statoconia will be bending, it will have a pressure on the, it will have a uh, effect on the bending of the hair tufts, and this will lead to an creation of the signal potential, and then that will be taken up by the nerve fiber. So the hair cells, they are oriented in relation to a ridge, which is called the striatum. I'll show you in a picture. This striatum is along the otolith organ. Now you know what are the otolith organs. These otolith organs, they contain the calcium carbonate stones which are embedded in the gelatinous layer. So these otolith organs, they have a ridge which is called the striatum, and these hair cells which you notice here, these hair cells are oriented in relation to the striatum. The hair cells, they synapse with the sensory endings of the vestibular nerve. These are the vestibular nerve. You know that while examining the cranial nerves, the eighth nerve which you say is the vestibulocochlear nerve. So it has two components, the vestibular nerve and the cochlear nerve. Cochlear nerve, you examine the hearing part of the ear, and with the vestibular nerve, the equilibrium or the balancing mechanism which is contributed by the ear is detected by the vestibular nerve. So these are the fibers which are part of the vestibular nerve. Now we'll see at what is striatum. Here what you see, this is an otolith organ, and this ridge which you notice in between, this is the striatum, and this is a structure of the saccule. Saccule is one of the otolith has a otolith organ. So this is the section which is showing the hair cells in relation with the streola. Now, if we see, we have to notice the increasing order of the hair cells, and we have to note the relation of the longest kinocilium to the striola. So I told you that the organ has hair cells. These are the hair cells, and these are the hair cells which have got cilia. And what you can note here is that all the cilia, they are not of the same length. In fact, there is an increasing order of the hair cells which you can very clearly appreciate in the picture, that these hair cells, they have an increasing order. Then another thing which you have to note here is that since this is the streola, so if it is cut, you can notice this ridge which is over here. So this is the streola, and you can notice one striking feature over here is that the arrangement of the kinocilium. Kinocilium is the longest hair cell over here, longest cilia over here. So this one is the kinocilium, kinocilium, this is the kinocilium. The longest which you see is the kinocilium. So what you note here is that this is the striola. Thus, the cilia which are present on the other side, they have longest kinocilium situated away from the striola. Whereas on this side, the longest kinocilium is situated on the other side. So this is the arrangement of the kinocilium. It is present, it is arranged in relation with the striola. So this is what I was mentioning in this previous slide, that the hair cells, they are oriented in relation to a ridge which is called the striola. Now, since there are two organs, what you see, macula utriculi and the macula saculi. So let us see how the hair cells in these two organs are arranged. The macula of the utricle, it lies mainly in the horizontal plane. Utricle responds to horizontal acceleration. So this is a very important point. I have highlighted it, and it's shown in the red color. Utricle responds to horizontal acceleration. The hair cells on either side of the striola, they are polarized towards the striola. So what does this mean? You can note the arrows. So this is the structure of the utricle. What you see, the if this is the striola, all the arrows which are to the lateral side, they are pointing towards the striola, and all the arrows which are on the medial side, they are pointing again towards the striola. So it shows that in this structure, in this utricle, the cells will depolarize when the kinocilium will bend towards the striola. That is called polarization. So what I mean by polarization is that when will the kinocilium depolarize, in what direction of bending of the kinocilium it will depolarize. So in this structure you can see that this kinocilium is arranged towards the striola, so it will depolarize when it bends towards the striola. So this is the structure of the macula utriculi. Now let us see the macula saculi, which we have seen in the previous diagram. All the kinocilium which you saw in the previous diagram, they were present away from the striola. You can notice in this picture, in this diagram, this is the striola, and all the arrows, they are moving away from the striola. So that means if the kinocilium will bend away from the striola, this structure is going to depolarize. Okay. Now, let us just correlate this with the previous picture. What you see here, this is the striola, and these are the kinocilium. So if this kinocilium bends away from the striola or in this direction, then this hair cell will depolarize. And on this side, when this kinocilium bends away, that is this side, then this hair cell is going to depolarized. So that is called the polarization. So here you see that in the macula utriculi, the polarization is towards the striola, and in the macula saculi, the polarization is away from the striola. So this is a picture showing the hair cells. Each vestibular hair cell contains a set of stereocilia on its apical surface and a large single kinocilium. So what is shown here is a large single kinocilium, and these are the stereocilia. Bending the pile of stereocilia towards the kinocilium increases the tension on the attachments. So what you note here, this is an increasing order of the hair cells, and the longest one is the kinocilium. And the polarization of this kinocilium can be towards the striola or it can be away from the striola. So what you note here, the filamentous attachments between the hair cells. If there is bending of the hair cells, then it can tend to pull these filamentous attachments. The bending of the pile of stereocilia towards the kinocilium increases the tension on the attachment. So if this is going to bend towards the kinocilium, this will increase the tension on the attachment. This movement opens the ion channels, thus causing receptor depolarization. So that is how it works. When this kinocilium and these hair cells bend towards the kinocilium, it leads to uh, put pressure or tension on these filamentous attachments. And this tension can lead to opening of the ion channels, and subsequently it leads to depolarization. So let us see how it takes place. These are the hair cells. You can see the fine attachments between them, which are called the tiplings. Tiplings. So a positive deflection towards the tallest stereovilli, it will open the apical channels, leading to the influx of potassium, and it will lead to depolarization. So this is how you see. These are the hair cells, and in this picture they are bending towards the longest stereocilia, that is kinocilium. They are bending towards this direction. So when they bend, it tends to put pressure on the tiplings. It leads to open the ion channels, potassium channels, and there is influx of the potassium in this hair cell, and that leads to depolarization. What you see here, depolarization. Now when there is depolarization, a negative deflection will close the apical channels and thus lead to hyperpolarization. What do you mean by negative deflection? That is, when in this direction, in this diagram, what you see is a negative deflection. That is, all the hair cells, they are bending away or in opposite direction of the tallest, longest stereocilia. So when this is bending away from the stereocilia, this is tending to close the apical channels, and there is hyperpolarization. So what happens with the depolarization? With the depolarization, there is opening of the voltage gated calcium channels, there is influx of calcium, there is release of neurotransmitter from the vesicles, and there is conduction of the action potential. So let us revise the vestibular transduction. The hair cells releases an excitatory neurotransmitter, which may be either glutamate or aspartate, tonically, and so that the afferent fiber on which it synapses has a resting discharge. This is a resting discharge which is provided by the tonic release of the excitatory neurotransmitter. When the stereocilia are bent towards the kinocilium, the conductance of the apical membrane increases for potassium, and it enters the vestibular hair cells, or there is potassium influx when the stereocilia are bending towards the kinocilium. So when the hair cell is now depolarized, more neurotransmitter is being released, and the discharge rate of the afferent fiber increases. So this discharge rate is over this tonic release of the neurotransmitter, or the tonic uh, potential in the afferent fiber. When the cilia are bent away from the kinocilium, the hair cell is hyperpolarized, as I've just shown you in the previous picture. less neurotransmitter is released and the firing rate of the afferent fiber slows down. So this is now you can summarize here that bending of the stereocilia towards the kinocilium will lead to depolarization because of the opening of the apical channels, and there will be a potassium influx. Whereas the bending of the stereocilia in the opposite direction, that is away from the kinocilium, will close the apical channels and it will lead to hyperpolarization. This is the diagram showing the functional polarization of the vestibular hair cells. Now what you see, this is the kinocilium. These are the hair cells. So as far explained, this cell is going to depolarize when these hair cells will bend towards this kinocilium. So now let us follow this picture. This is a normal position. This is the resting discharge. As I said, a normal hair cell will have a very low level or a tonic release of the neurotransmitter, and there will be a resting discharge. So these lines are showing the resting discharge. Now what happens? The hair cells or the stereocilia, they are bending towards the tallest stereocilia or the kinocilium. Then this leads to depolarization, and with depolarization there is increase in the release of the neurotransmitter. So there has to be increase in the impulse frequency, and this is depicted here in this picture. Depolarization will lead to increase in the neurotransmitter release, and there will be increased firing in the nerve. So that increased firing is shown with the help of very closely placed black lines. Now what happens? Again, this goes back to normal resting position, and this again shows the resting discharge. What happens with hyperpolarization? These hair cells, they bend away from the tallest kinocilium, and the tipplings will close, the apical channels will close, and there will be hyperpolarization. So that hyperpolarization has been depicted with uh, black lines which are positioned at a distance. So this is showing decreased impulse frequency. And here you can appreciate how this functional polarization works. Functional polarization means this cell is going to depolarize if the hair cells bend towards the kinocilium, and if they bend away from the kinocilium, this will hyperpolarize. Okay, so this is how the working of otolith organs occurs. In any particular orientation of the head, the cilia of the hair cells are bent to varying extents according to their orientation in relation to the gravitational vector. And this results in a particular pattern of input from the otolith organs to the CNS. When the head is tilted to a new position, the orientation of the otolith membrane in relation to the gravitational vector changes, and so the cilia of the hair cells are bent in a new way. This change in the bending of the cilia of the hair cells changes the pattern of input from the otolith organs to the CNS, and this will create the sensation of movement. So this is how the otolith organ works. Now coming to the next, that is semicircular canals. You know that there are three semicircular canals. Let's see how they are oriented and how they work. The semicircular canals are horizontal, anterior and posterior canals. So again you can appreciate one is horizontal, one is anterior and one is posterior. They are not in the same plane. The orientation or relationship of the canals you can appreciate from this picture. This is the left superior semicircular canal. This is the horizontal semicircular canal. This is the left posterior semicircular canal. The right superior canal and the right posterior canal, they are positioned at 90-degree angle. So the important role of semicircular canal is in judging the angular acceleration. The semicircular canals on each side of the head they correspond. And angular acceleration generated by the sudden head rotation is the primary stimulus for the semicircular canals. So, in the previous uh, discussions, in the previous explanations of the otolith organ, you have seen that they are mostly concerned about the linear acceleration. Here, angular acceleration, which is generated by sudden head rotation, is the primary stimulus for the semicircular canals. So each semicircular canal has a swelling, which is called an ampulla. There you learnt about the macula utriculi and the macula saculi. Here what you will learn is the ampulla. And each semicircular canal has a swelling which is called the ampulla at the point where it joins the utricle. So now this you can appreciate from this diagram. This is the ampulla or the swelling. Each semicircular canal, you can appreciate that there is a swelling. This is the ampulla. Here another ampulla is over here, and this is the another ampulla. So three semicircular canals have a dilated portion which is a swelling type of structure which has ampulla, and this is called the ampulla, and it is present at the point where it joins the utricle. So you can also appreciate the utricle and the utricle and the saccule in this picture. The lower diagram shows a clearer view of the ampulla. So what you can appreciate, this ampulla contains a sensory epithelium which is called the crista ampullaris or the ampullary crest. It contains, this is the ampulla or the dilated portion. It contains crista ampullaris, and this crista ampullaris is the sensory epithelium. The ampullary crest consists of a ridge transverse to the long axis of the canal that is covered by epithelium containing vestibular hair cells. What you can appreciate here are the vestibular hair cells, and this is a cupula, which is a gelatinous structure which is present over here above this crista ampullaris. This hole is the ampulla, this is the sensory epithelium, and these are the hair cells. These are the this is the semicircular canals, and these fibers are the axons of the vestibular nerve. So now we will see how this works to make us appreciate or uh, help us in the head rotation and balancing of the body. Hair cells, they are innervated by primary afferent fibers of the vestibular nerve. As I've told you that vestibular nerve, if you are testing equilibrium, maintenance of equilibrium, you have to test the vestibular nerve. Then the cilia on the ampullary hair cells, they are embedded in a gelatinous structure which is called the cupula. Cupula and the crista, they occlude the lumen of the ampulla completely. So what you can, this coming back to this diagram, this is the ampulla, this is the crista ampullaris, this is a gelatinous structure which is called the cupula, and this whole thing is occluding the lumen of the ampulla or this semicircular canal. It is occluding the lumen. Movement of endolymph, which is produced by the angular acceleration. Again, you can note the word. I've highlighted it. I have made it in red color. So remember this angular acceleration of the head about an axis which is perpendicular to the plane of the canal, deflects the cupula and bends the cilia on the hair cells. So movement of the endolymph, which is produced by the angular acceleration of the head about an axis perpendicular to the plane of the canal, will be able to deflect the cupula and bend the cilia on the hair cells. So this direction is very important. If the movement of the endolymph is in this direction, it will lead to bending of the cilia, and it will be perpendicular axis. The axis will be perpendicular. What you have to note here, and a very important point, is that cupula has the same specific gravity as the endolymph, and thus it is unaffected by linear acceleratory forces such as gravity. There, in the macula utriculi and macula saccule, you had seen the otolith organs, and the specific gravity was twice as that of the endolymph. But here, the specific gravity is the same. So that is why it is not affected by the linear acceleration. This here you can appreciate the ampulla better. This is the sensory epithelium or the crista ampullaris. This is a gelatinous structure which is called the cupula, and these hair cells, they are embedded in the gelatinous uh, layer which is the cupula, and all this is blocking the lumen of this semicircular canal. This is the ampullary portion of the semicircular canal. Here is the endolymph. So if endolymph is coming this direction, it will tend to bend the cupula, and this will lead to firing of the action potential from these hair cells. It will be transmitted through the vestibular fibers of the vestibular nerve. If the head acceleration occurs in this direction, endolymph will move in the opposite direction, and it will move in the opposite direction. Now again, correlating the functional polarity in the hair cells. All the cilia in a given ampullary crest are oriented in the same direction. This is the crista ampullaris. You can see the dilated portion of the semicircular canals. This is the crista ampullaris. Here, what you should note is that all the hair cells, they are directed in a single direction. So this is a difference from the two structures which you have read before, the macula utriculi and the macula sacculi, where you learnt about the striola, which is the reversal line. These hair cells on either side of the striola, they are in present in opposite direction. Here also you can see they are pointing towards the striola. Here they are pointing away from the striola. But in case of crista ampullaris, they are all pointing in the same direction. In the horizontal canal, the cilia are oriented towards the utricle, and in the other ampullae, they are oriented away from the utricle. So the only difference is that whether they are oriented towards the utricle or they are oriented away from the utricle. But all will be oriented in the same direction as compared to the saccula utriculi and the uh, macula utriculi and the macula sacculi. Angular acceleration of the head produce minute movements of the endolimb in relation to the head. And this happens because the inertia of the endolimb causes it to resist the initial acceleration of the membranous labyrinth. This lag pushes to the cupula, causes the cilia to bend, and consequently changes the discharge rates of the vestibular afferent fiber. Now let us see how it is occurring. This diagram, it shows the effect of leftward head movement on the activity of the vestibular afferent fibers, which are supplying hair cells in the horizontal semicircular canal. So out of the three semicircular canal, we are right now talking about the horizontal semicircular canal, and let us see how this head movement can bring about the uh, depolarization in the hair cells of the horizontal semicircular canal. So these are the horizontal semicircular canals of the two sides, right and left side. Okay. When the motion of the head is towards this side, okay, when the head is turning towards the left, that is leftward head movement. When the head is moving towards this side, there will be an inertia in the endolymph which is present in this horizontal semicircular canal. It will lead to a fluid motion in the opposite direction. So if one is turning head towards the left side, the endolymph will move in the opposite direction. So for this left semicircular canal, it will move in this direction, and it will push the hair cells towards this direction. That is towards the functional polarity of the hair cells on the left side. On the right side, what happens? When this fluid, when the head is turned towards left side, the fluid moves in the opposite direction. and this tends to, it does not lead to a stimulation of the hair cells because the functional polarities of this hair cells is just opposite to the movement of the endolymph. So subsequently you can see the nerve impulses being generated from the two sides of the fibers. Here what you see, when the head is rotating towards the left side, the endolymph moves in the opposite direction. It pushes the hair cells and they are bending towards the kinocilium. There is a discharge of the impulse, and this is appreciated in the form of increased firing. Here what happens? Fluid motion is not able to stimulate the hair cells because their functional polarity is just opposite to that of the movement. So this, there is no signal as such. It rather decreases. So this you can appreciate in the form of far positioned black lines. That is, there is a decrease in the firing. So, summarizing this picture, head rotation to the left causes endolymph pressure to the right, and this results in the increased output from the left canal and decreased output from the right canal. So now you should be able to appreciate how this semicircular canal is working. If this is a horizontal semicircular canal, if one is moving to the left direction, it is the left semicircular canal which gets activated and it tends to increase the firing, and this firing will go and it will inform the brain that, see, now the movement has to be brought about in the opposite direction so that the body and the head are balanced. So this is how the semicircular canal works. Now this shows the uh, pathway of the vestibular apparatus. From the utricle semicircular canals, these fibers they go, and this is the vestibular ganglion, and the fibers they go to the cerebellum, they go to the somatosensory cortex, they also go to the other area, to the spinal cord, and these connections are cumulatively helping in balancing the body. Not just the vestibular apparatus is able to do it alone. There has to be a role played by the cerebellum, a role played by the spinal cord, and all these connections are meant to make this process very easy. So let us have a look at the central vestibular pathways. The vestibular afferent fibers, they project to the brainstem through the vestibular nerve. These primary afferent fibers, they terminate in the vestibular nuclei, which are located in the medulla and caudal pons and in specific regions of the cerebellum. As I told you that balancing, you, when you read about cerebellum, you must have read about the how the cerebellum is also able to bring about the equilibrium in relation with the vestibular apparatus. So again, this is coming back. You can revise it over here. The vestibular nuclei give rise to various projections, including projections through the medial longitudinal fasciculus to the oculomotor nuclei. Oculomotor nuclei, this will help in bringing about the vestibulo-ocular reflex. That is, when you are moving and your eyes are focusing on an object, then it should keep on focusing on that object despite the movement of the body. And that can only be brought about with the help of the vestibulo-ocular reflex. The vestibular nuclei exerts powerful control over the eye movement with the help of the vestibulo-ocular reflex. Projections give rise to the lateral and medial vestibulospinal tracts. That is, definitely there has to be it has to work in conjunction with the spinal cord, because it has to send information to the muscles for bringing about the reorientation of the body. So there has to be connection with the vestibulospinal tracts. These provide for the activation of trunk and neck muscles, and thereby they contribute to the equilibrium and to head movements through the vestibulo-colic reflex. There are vestibular pathways to the cerebellum and the reticular formation and the contralateral vestibular complex, as well as to the thalamus. So this is the final slide, which is showing the functional divisions of the cerebellum, and it shows this is the spinocerebellum. Here, what you note is the vestibulocerebellum, and this is the part of the cerebellum which works in uh, conjugation with the vestibular nuclei. So both of them, they help in balancing the eye movements so that we are able to focus on the object of interest. And despite our head movements or despite our body movements, we are able to focus on an object. So, summarizing this lecture was about the working of the vestibular apparatus. Here today you learnt about the two organs which are the otolith organs, the macula saculi and the macula utriculi, which have the mm, which have the organs, which have the otolith organs, which help in detecting the acceleration, head movements. And apart from that, there are three semicircular canals which are present in different planes, and they also help to appreciate the head rotation, the angular rotation, and they help in bringing about an opposite movement of the head and the body so that we are able to balance or bring about the equilibrium of the body. So that was all about the vestibular apparatus. Thank you.
Very good morning. So today I'm going to discuss regarding phenylketonuria. So the objectives of today's class. So at the end of this class, you should able to discuss what are inborn errors of metabolism and in detail about phenylketonuria and how to diagnose phenylketonuria and its management, and just we something we touch upon is newborn screening. So before going to our today's class, phenylketonuria, so we just look into a case study. A 6-year-old boy was referred to the hospital with the problem of aggressive behavior and developmental delay. At the age of 1 year, the mother noticed that child's normal black hair gradually changed to light brown. There was no history of light hair on both parental sides. The parents were first cousins, and one of the maternal grandfather was mentally retarded. So if you see the important key points, so a 6-year-old boy and 6-year-old boy, and he has a aggressive behavior with a developmental. Developmental means the usually we have like at the age of 3 months, the child should hold its neck. This is a neck holding at the age of 3 months. Then again at the later he start crawling, then it's a sitting, crawling and standing. So these are the things which are delayed in the child, and also the child has some aggressive behavior. Other thing is that a normal black hair color texture is changed into gray or light brown. So the change in the color, that is which we call it as a, sometimes we call it as a hypopigmentation. So the child has a developmental delay, the aggressive behavior and the hypopigmentation. And again, there was no any history of light hair on the both parents. Both the mother and father appears to be normal. Again, if you see the pedigree chart where the parents were first cousins, means there is a history of consanguineous marriage, and one of the maternal grandfather was mentally retarded, means there is a some mental retardations or a developmental delay which has taken place in his family. So it tells you about the inheritance of a disease. So each one of these findings or the features, what is the cause for this, we will study in the subsequent slides. Just remember the case study. Okay, now moving on to the what is errors in metabolism. So if an error occurs in the gene which codes for an enzyme, then obviously there is a fault occurs. Subsequently, what happens? The enzyme is not produced, so the metabolic pathway breaks down. This we call it as inborn errors of metabolism. So why we say inborn is it is seen with the birth of a child. Maybe that presentation will be within a 1 year or in the later life of a child, based on which metabolic pathway it is going to get affected. So these inborn error of metabolisms, in simple we call it as AIIMS. They are uncommon but complicated medical conditions involving abnormalities in complex biochemical and metabolic pathways. The concept of inborn errors of metabolism was first introduced by a physician known as Sir Archibald Garrod in the year 1908. He mainly worked on alkaptonuria. So again, he coined the term called the Garrod's tetrad, which includes the four inborn errors of metabolisms like alkaptonuria, the albinism, and cystinuria, which are associated with the amino acid metabolism disorders, and pentosuria, which is associated with the carbohydrate metabolism disorder. This we call it as a Garrod's tetrad. So coming into the details of inborn errors of metabolisms, these are disorders due to deficiency or absence of an active enzyme in a metabolic pathway. Just on a hypothetical metabolic pathway where the substrate A is converted into product B with the help of enzyme A, and this product B again it acts as a substrate for the sequential substituent reactions. So the enzyme B converts B into C. Same way we have enzyme C which converts the substrate C into the end product of D. So this is the major pathway where the A is converted to B into C into D. It is a major or a main metabolic pathway. There is existence of a minor or alternative metabolic pathway where this C can get converted into E and this E can get converted into F. So many times this alternate pathway will produce the undesirable products. So normally this is a major pathway which is going to take place in our body. So what is happening in inborn errors of metabolism? So if in the same example, if I consider if there is a deficiency of enzyme C, so obviously the product D is not going to produce. Instead, so what we're thinking about the minor or alternate pathway, it becomes a major pathway where the substrate C is get converted into E and that converted into F. So in nutshell, in case of inverse errors of metabolism, there is a three thing will happen. The first thing is decreased synthesis of important metabolites which are needed for our body. So there is a decreased synthesis. At the same time, there is a accumulation of substrate. And this accumulated substrate is, there is a conversion of substrate into other, often it is the undesirable compounds. So which usually sometimes cause some toxic effects in our bodies. So just remember the three important points in inborn errors of metabolism. Due to the deficiency of a particular enzyme, there is a decreased synthesis of important metabolite, the accumulation of substrate, and this accumulation of substrate is diverted to formation of a undesirable compounds. The same again in a schematic view, say there are the enzymes. So this funnel, you just consider it as a metabolic pathway having a multiple enzymes. So this is the substrate. They enter into a metabolic pathway, that is a funnel. Then they producing the product, and the products they are recycled. So it is a normal physiological biochemical reactions. So if there is any obstruction in the funnel, or if I say there is a absence or a defect in the enzymes, what will happen? The substrate is not get converted into product. So there is a substrate accumulation. Over the period, due to the law of mass actions, what happens is substrates, the accumulated substrate will in turns leads to cell damage and death. So what is happening in case of inborn errors of metabolism? So these AIIMS are rare in occurrence. they detected most frequently at infancy. Infancy means from birth to 1 year of age. Some are very fatal at early age, and if untreated, they commonly cause the irreversible damage to the nervous systems. So once the damage occurs, it is irreversible. So that is why once we have to detect these IMs as early as possible so that we can prevent the irreversible damage to the nervous system. So coming to the inheritance of these IEMs, so most of the inborn errors of metabolisms are autosomal recessive. So I think everybody knows what is autosomal recessive, what is the inheritance. So just a recapitulation. So in case of autosomal recessive, both the parents are normal, but they are carrier of a defective gene. That is, they are heterozygous. There is a one, we know that for every gene we have a two alleles. So one is a maternal, another is a paternal allele. So one allele is affected, another allele is normal. So once they are carriers, so what is the chance of developing the inborn errors of metabolism in the subsequent pregnancy or a next pregnancy? So there is a chance that if both affected alleles, if they transfer to the child or a fetus, then that child has developed the IEM. So there is a 25% of child developing the disease. At the same time, there is a 25% chance the child born with a normal allele or a healthy child, or there's a chance that the 50% chance that the child has a carrier state. So this is the autosomal recessive. There are some inborn errors of metabolisms which are X-linked. So in that case, mainly the son are affected and mother is the carrier. So just remember, the most of the IMs are autosomal recessive inheritance. So there are different categories of inborn status of metabolisms. We probably divide based on which metabolic pathway is affected. So there is a amino acid metabolism disorders, carbohydrate metabolism disorders, fatty acid oxidation disorders, lysosomal storage disorders, urea cycle defects, peroxisomal disorders, and mitochondrial disorders. So today we are focusing on amino acid metabolism disorders. In that, again, we are focusing particularly on aromatic amino acid in relation to the phenylalanine metabolism, that is the phenylketonuria. So amino acid metabolism disorders, they are heterogeneous group of disorders. If block occurs at an early step of a metabolic pathway, it results in accumulation of amino acids. If block occurs at a later stage of a metabolic pathway, it results in accumulation of the metabolites. And there's also a chance that there's a defect in the transport mechanism of amino acids, resulting in decreased intestinal transport, or there is a increased urinary excretion of amino acids. So in amino acid metabolism disorders, so we have many disorders like, for example, albinism. It is due to deficiency of tyrosinase. Alkaptonuria due to deficiency of homogentisate oxidase. Again, we have some urea cycle disorders like arginemia, arginosuccinic acidemia, carbamoyl phosphate synthetase 1 deficiency, sulfur containing amino acids like homocystinuria, or the branch chain amino acid disorders like maple syrup urine disease, methylmalonic acidemias, and the last one is the phenylketonuria. So if you see the approximate incidence, this phenylketonuria is more common incident inborn errors of metabolism in amino acid disorders. So most of these disorders are having the convulsion or the mental retardation as a one of the important clinical feature or symptoms. So again, in amino acid metabolism, as we discussed in the previous table, the IAM of aromatic amino acids, the IAM of branched amino acids, IAM sulfur containing amino acids, and so on. So here we are focusing on the aromatic amino acids. So we have four important inborn errors of metabolism associated with the aromatic amino acids. One is phenylketonuria, alkaptonuria, albinism, and tyrosinemia. But today we will focus mainly on discussion on phenylketonuria. As the name suggests, so if everybody remember, that's phenylketonuria. So that means there's something which is excreted in the urine, and that is the phenylketone. Don't confuse, it is a phenylalanine is transaminated to form a phenylpyruvate. So that phenylpyruvate is excreted in the urine. That is why we call it as phenylketonuria. And these phenylketonuria patients are having hyperphenylalaninemia. That means in their blood there is an increased concentration of phenylalanine is seen, but in a urine it is the phenylpyruvate which is water soluble and which is excreted in the urine. That is why we use the term phenylketonuria. So it is the most common inborn error of metabolism, 1 in 10,000 or approximately 10 in 1 lakh births. So it arises from three defects. So if you see the reactions where this enzyme is involved. So there is a defect in the phenylalanine hydroxylase itself. That is we call it as a type 1 or the classical phenylketonuria. And this phenylalanine hydroxylase enzyme requires a coenzymes that is known as a tetrahydrobiopterin. This tetrahydrobiopterin is produced by dihydrobiopterin with the help of dihydrobiopterin reductase. So if that enzyme is defect, there is no coenzyme of tetrahydrofolate, and obviously the enzyme activity reduce. So that is also leads to phenylketonuria. It is the type 2 phenylketonuria. If there is a defect in the coenzyme synthesis, that is the dihydrobiopterin biosynthesis defect, that we call it as a type 3 phenylketonuria. So in this phenylketonuria, there is the accumulation of phenylalanine and its metabolite in the blood. The pattern of inheritance for phenylketonuria is autosomal recessive. That means both the parents, they are carriers or they are heterozygotes, they are normal, and if the child has got both the defective allele, then he develop the disease. So this is the feline alanine metabolism. That is just I'm focusing on the first step where the L-phenylalanine is get into L-tyrosine. So why using the L? Because these are the L amino acids are the one which are most commonly seen in nature. And this is catalyzed, or this reaction is catalyzed with the help of phenylalanine hydroxylase. It is a mixed oxidase reactions because the two oxygens. So one oxygen is involved in formation of hydroxyl group of a tyrosine, and another oxygen is used in the formation of water. And here the tetrahydrobiopterin is reducing the phenylalanine to tyrosine, and this tetrahydrobiopterin undergoing oxidation to form the dihydrobiopterin. And again, this dihydrobiopterin with the help of NADPH and dihydrobiopterin reductase again it is resynthesizing the tetrahydrobiopterin. So this is a normal pathway. So the phenylalanine get converted into tyrosine, then tyrosine later get converted into homogeneous acids, and again so on. Or the tyrosine again is get converted into the important the metabolites like epinephrine, norepinephrine, dopa, and melanin. So what is happening in case of phenylketonuria? So in phenylketonuria, there is a deficiency of phenylalanine hydroxylase. So there is a no conversion of L-phenylalanine to L-tyrosine. So there is a deficient tyrosine or a decreased tyrosine levels or the absence of tyrosine levels. Instead, this accumulated phenylalanine get transaminated to form a phenyl pyruvate. So these ketones are high water soluble, so they excreted in the urine. That is why we use the term phenylketonuria. And again, this phenyl pyruvate again spontaneously they get converted into phenyl acetate or the phenyl lactate, and these are the one which again give rise to they are again excreted through the sweat that leads to mousy body odor in case of phenylketonuria. The other important thing is you have to remember that tyrosine you usually call it as a non-essential amino acid because it is already synthesized in our body by the phenylalanine. So we don't require this tyrosine by the diet. But in case of phenylketonuria, there is no production of tyrosine from the phenylalanine. In that state or in that condition, this tyrosine is become a essential amino acid. So we must supply these tyrosine in the diet of a child who has developed the phenylketonuria. So in phenylketonuria, there is a accumulation of substrate L-phenylalanine. There is a decreased synthesis of the important metabolite tyrosine and the conversion of substrate into undesirable products like phenyl pyruvate or phenyl lactate and phenyl acetate. So come to the clinical manifestations. Again, if you remember, we start with the clinical case. The child has developed the agitations, the aggressive behavior, the developmental delay, and again the light coloring of his hair, that is or brown color of a hair that is called hypopigmentations. So these are the important clinical features of a phenylketonuria. The classical phenylketonuria child is mentally retarded with an intelligent quotient of 50 or less than that. Normally, the child develops the agitations, the hyperactivity, tremors, and convulsions. So it is a why it is a reason because the phenylalanine, increased concentration of phenylalanine will in turns compete with the transportation of other aromatic amino acids like tyrosine and tryptophan. And these are again involved in the suffer very important neurotransmitters. From tyrosines, we are getting the dopa, the epinephrine, norepinephrine, or from tryptophan, we are getting the serotonin. So that is how why these the children they or the patients are having some neurological symptoms. They often present with hyperpigmentation because the tyrosine is the one which is mainly involved in synthesis of melanin. So if there is no tyrosine, obviously there is no melanin. So that is why the child has developed the hypopigmentation. The phenyl lactate and the phenyl acetate in sweat, they can leads to mousy body odor. So these are the classical symptoms which are seen in case of phenylketonuria patients. Now, how to diagnose a phenylketonuria? So the laboratory diagnosis. So before that, just we know what is screening. So the early diagnosis and the appropriate treatment can alleviate or reduce the symptoms. So this early diagnosis can be achieved by a screening test. So in any disease course, we have a disease onset and we have a usual time of diagnosis. So before that, we have two more important things. One is the first possible detection by measuring the important metabolites or important changes. And there is the final critical point. Beyond that point, whatever the treatment modality, they will not reverse the, the symptoms which are already taken place. So the screening time is the one which expands from the first possible detection to the final critical point. So if we apply a test during this phase or during this period, we can prevent the irreversible damages. So the child has a better outcome. If we diagnose a disease after the final critical point or the usual time of diagnosis means that once a child develops some clinical symptoms. So in that time, the already the irreversible changes has are taken place. So we not able to revert normal state. So this is a screening time. So there is something difference between the screening test and diagnostic test. So just I will go on. Like screening tests are usually done on a apparently healthy individuals, whereas diagnostic tests are usually done on a sick or with the overt indications. Screening tests are more sensitive, but they are less specific. They usually find the true positive who are having the disease, whereas diagnostic tests are more specific. Usually they look for the true negative. So the results are incomplete and only gives a hints for a disease in case of screening test. So once you do a screen test, then to confirm it, we should go for diagnostic tests. So that's why the diagnostic test, the results are complete. Screen test, the positive result is not a basis for a treatment. So in that case, if the screen test comes positive, then we should go for a diagnostic test or we have to follow up the case and we do the surveillance. Whereas the diagnostic test, once it comes a positive, so it is the basis for the treatment. Screen tests are usually cheap, they are economical. Diagnostic tests are comparatively expensive. So again, in case of IEM, we have a screening test, and again we have confirmatory or the diagnostic tests. So come to the phenylketonuria screening test. So a very important is Guthrie's bacterial inhibition test. So why we say bacterial inhibitions? Because here we are taking a particular species of a bacteria, that is Bacillus subtilis, and the peculiarity of this bacteria is it is dependent on phenylalanine for its growth. So if you provide a phenylalanine, then only it grows. If there is a decrease or absence of phenylalanine, it never grows. And usually we grow these bacteria in a culture medium. So we are adding another important compound which we call it as a beta 2 thionylaline. It is a phenylalanine analog and it is acts as a competitive inhibitor. So once you add this competitive inhibitor beta 2 thionylalanine, it competes with the phenylalanine, so it stops the bacterial growth. Okay, so what we are doing in case of this Guthrie's bacterial inhibition test, so we are adding we are adding the we are growing the bacteria in culture medium with beta 2 thianalin, and we are adding the normal infant. We know that normal infant, they have a very less amount of phenylalanine. So normally the blood level of phenylalanine is 1 to 2 milligram per deciliter. So obviously when you add a normal infant blood, there is a no bacterial growth can seen in the culture or agar mediums, because this beta 2 thianalin is inhibiting the bacterial growth. In other, well, we add the blood from a phenylketonuria patient, and we know that in phenylketonuria patients there is a increased amount of phenylalanine. So is approximately around to 20 to 70 milligram per deciliter of phenylalanine is seen in case of phenylketonuria. So in that case, the bacteria grows. So this is how it looks. For example, if you see on periphery, we are having the positive control. Positive control means we are having the phenylketonuria or the increased phenylalanine containing blood sample. And it is an agar plate where we added the bacillus subtilis along with the beta 2 thialanine. So if you see here, there is no growth of bacteria. The growth of bacteria is visible by increase the, the opacity. This white color, what we are seeing, it is showing the bacterial growth. So these are the two cases where there is a bacterial growth is seen, and this blood sample represents the sample of a phenylketonuria patient. There are other tests which can detect the phenyl ketones like phenyl pyruvate, like we have a ferric chloride test where the phenyl pyruvate reacts with ferric chloride, it forms the green or a blue color. The other test is the dinitrophenyl hydrogen, that is the DNPH test. So here the again the same, the phenyl keto acids, phenyl pyruvate, it forms the yellow precipitate with DNPH reagent. So we have a three screening test. One is on the blood sample, that is the Guthrie's bacterial inhibition test. The two are on a urine based test. One is the ferric chloride test, and there is the dinitrophenyl hydrogen test. So these are the screening test. Again, we have a definitive diagnosis or the confirmatory test for the phenylketonurias. So definitive diagnosis is to measure the enzyme levels or their activity in the cell. So normally we look for the enzyme activity in leukocytes or the fibroblasts or in blood. Second, we can also go for prenatal diagnosis where we can measure the enzyme levels or activity in the cultured cells from the amniotic fluid. Third, we can go for molecular genetic techniques like DNA or RNA based by using the chorionic villus sampling or by going for a amniocentesis. So the confirmatory test is to look for the enzyme levels or enzyme activity, or to look for any mutation in the gene or a DNA which is encoding the phenylalanine hydroxylase enzyme. Next, coming to management. So the management is here, there is no any curative treatment for any inborn error of metabolism. For curation, we need a gene therapy where we can replace, replace the defective gene by a normal gene. But this gene therapy is under a experimental stage for inborn errors of metabolism. So only we can prevent the mental retardation in a child if we diagnose these inborn errors of metabolism as early as possible, probably within a infancy, within a 1 year of age. So if you detect a child within a 1 year, so we should follow a rigid dietary control. So what is that rigid dietary control? The diet must supply enough phenylalanine and tyrosine to meet the needs for the protein synthesis, because these two are required for synthesis of important metabolites. Like for example, the phenylalanine gets into tyrosine. The tyrosine is involved in synthesis of epinephrine, norepinephrine, dopa, melanin, and thyroid hormones. So we should supply, but only the enough, not the excess. Avoid consumption of protein-rich foods in the diet, or we say the phenylalanine restricted diet. The natural proteins such as casein of milk must first be hydrolyzed, and much of the phenylalanine is removed before given to the child. And most of the processed food, they are having the some artificial sweetener like aspartame. You should remember that this aspartame is a dipeptide having the aspartate and methyl ester of phenylalanine. So always avoid these aspartame containing artificial sweetener to the phenylketonuria patient. So considering these, because once a child develops the phenylketonuria or any other inborn error of metabolism, that leads to uh, emotional disturbances in the parents, and that leads to some the economical burden on the parents as well as the government. That is why the most of the countries through worldwide, they come up with the uh, health programs which we call it as a newborn screening programs. So in newborn screening programs, as the name suggests, so if you detect the preventable inborn errors of metabolism as early as possible, we can prevent the the morbidities or the economical burden on the parent as well as the government. So in this figure, it is the older statistics where it shows that most of the America, the South America, the European countries, they have full population newborn screening programs. So whenever whatever the child is born, they go for a newborn screening. Then rest countries, some countries have a screening program 40 to more than 40% of the population or less than 40%. In India also, we are not much doing so much of newborn screenings. We are falling in a little or a no screening program. So for that we usually do the heel prick procedure or heel stick procedures, and usually we do these inborn errors of metabolisms after 24 to 40 years of after birth, within 72 to 96 hours. Why? Because once a child taking the breast milk, then from that, whatever the proteins that are amino acids, they are broken down and they forming the some metabolites. So that metabolites we want to detect. So here we are putting 1 or 2 drops of blood on the spot. So normally we call it as a dried blood spot. From that dried blood spots, we extract the analytes. So in higher or very developed centers, they are going for a tandem mass spectrometry, where they can go for more than 100 analytes measurement in a one go. Or normally we can also go for the high performance liquid chromatography technique. So there are some mandatory heel prick tests which are currently doing for some of the important inborn errors of metabolisms like congenital hypothyroidisms, G6PD deficiency, sickle cell anemia, cystic fibrosis, and as well as the phenylketonuria. So, in summary, phenylketonuria is the very common or most common inborn errors of metabolism of amino acid. As the name suggests, there is a excretion of phenylketone, that is a phenyl pyruvate in the urine. That is why we call it the phenylketonuria. And the patient had a increased phenylalanine in the blood. So there are three important screening tests. One is Guthrie's bacterial inhibition test, the ferrichloride test, and DNPH test to diagnose the phenylketonuria. These are the screening tests, and confirmatory tests are mainly the measurement of enzyme levels and enzyme activity. The management, early diagnosis, and rigid dietary control. So only provide the enough phenylalanine and tyrosine for the protein synthesis, and you can restrict the phenylalanine diet. Thank you.
Good morning, everyone. So, today I'll be teaching you about the basics of the cell membrane. This is an important topic nowadays, given everything that is going on. I'll come to why a bit later. Uh, just before that, if you can confirm that you are able to hear me, can you please confirm in the message that you are able to see the slides and you are able to hear me? Can you please see the slide? Anyway, I see there are only 3 people, so maybe. So I'll just start with the presentation. So cell membrane structure and function. So what is the cell membrane? The cell membrane is also known as the plasma membrane, and it is the boundary that separates the living cell from its surroundings. And this is important because we need to maintain a steady environment inside the cell so that all the cellular function can occur in optimum conditions. So this steady environment is known as homeostasis. Another important property of the cell membrane is that it is selectively permeable. Again, important to maintain the homeostasis so that even if the outside environment composition changes, the inner cellular composition does not change. Okay, so that is why it is selectively permeable, that is allowing some substances to cross it more easily than other compounds, and it is impermeable to most polar or charged compounds. Now, what is the cell membrane composed of? So it is composed of a phospholipid bilayer with a collage of many proteins, lipids, and carbohydrates. Okay, so what is a phospholipid then? So a phospholipid is a compound lipid which is formed from one glycerol molecule and two fatty acid and one phosphate group. So as you can see, let me bring out the pointer. So this, as you see, these are the two fatty acid chains, and you have a phosphate group to which another. So uh, this is actually a choline molecule that is attached here. So that is one type of phospholipid you will get. So there will be a phosphate group, and there will be at least two fatty acids esterified with the glycerol molecule. Okay, so what this does is the fatty acids are always non-polar compounds, but the phosphate, it has a very strong negative charge on it because of the oxygen atoms. So this creates a hydrophilic or charged, the or hydrophilic basically means it is soluble in water. So a hydrophilic head and a hydrophobic tail, which is the fatty acid tail, while the phosphate head is the hydrophilic head. Okay, so what is the basis of this plasma membrane structure? The glycerophospholipids, sphingolipids, and sterols spontaneously form if you just put them in a water-like solution, an aqueous solution. Then these lipids being having parts of both hydrophilic and hydrophobic parts, they will spontaneously form microscopic lipid aggregates. Okay, so that in such a way that their hydrophobic ends will be kept away from the aqueous solution, and only the hydrophilic heads will interact with the water molecules, and that is why they spontaneously form these microscopic aggregates. As per the type of lipids, there can be three different types of aggregates. Type of lipids or the amount of lipid present and the other basic components present, there can be 3 different types of lipid aggregates. And if you recall a bit of thermodynamics that you have read in your class 11 and 12, you will recall that the lipid clustering reduces the amount of hydrophobic surface exposed to water. And this will minimize the number of molecules in the shell of ordered water at the lipid water interface. So the lipid water interface, and the lesser the amount of water, there'll be therefore and more stable the system is. So if you can remember a bit of thermodynamics, this will lead to a increase in the entropy. So hydrophobic interaction with lipid molecules provide the thermodynamic driving force for the formation and maintenance of these clusters. Okay, so that is why thermodynamically it favors the formation of the aggregates. So individual lipids are wedge shaped, okay, with a bigger phosphate group containing hydrophilic heads, while the fatty acid tails are narrower. So the acyl chains get sequestered towards the interior, and that is they are kept away from water, and the polar heads from the water lipid interface, and this leads to a form of the spherical aggregate which is known as the mycelium. However, if you the second type is the lipid bilayer. So individual lipids are again cylindrical in shape in case of glycerophospholipids and sphingolipids. This is because the sphingolipids itself, the structure is different. It's a sphingol, the alcohol moiety is sphingol. So it is a more cylindrical in shape. So the hydrophobic portion in each monolayer excluded from the water interact with each other. The hydrophilic head groups interact with water at each surface of the bilayer. So if you have a glycerophospholipid and a sphingolipid, if you put glycerophospholipids and sphingolipids in the aqueous solution, you will get a lipid bilayer instead of just a mycelium. So depending on the individual lipids that are present, like in case of lysophospholipid, you will get a wedge shape. But in case of glycerophospholipids and sphingolipids, you will get a cylindrical shape. So on the basis of that, you will either get a mycelium or you will get a lipid bilayer. So, but this lipid bilayer is again, if you can see here, these sides, these are hydrophobic sides. Okay, so this whole region is hydrophobic. So even this is in contact with your water, okay, which is not thermodynamically favorable. So obviously the system will try to reduce this, reduce the interaction between water and the hydrophobic regions. So this leads to curving of and bending of the membrane and formation of a hollow vesicle of liposome, which is also known as liposome, with a separate aqueous compartment inside. So here you see, this is the aqueous compartment. This is the first layer of hydrophilic phosphate containing heads. This is your hydrophobic region, and again the outer shell of hydrophilic region. Okay, so you got mycelium, you got lipid bilayer, and you got a liposome. So now we know why there is a formation of the lipid bilayer in a spherical format, in which and which can house a your aqueous inner layer. So now let's come to the now let's come to how scientists discovered the structure of the cell membrane. So in 1935, Davison and Danelli proposed a sandwich model in which a phospholipid layer was lying between two layers of globular proteins. As you know, proteins will always be there on the surface. They need the proteins are needed for interaction between different cells, between different interleukin cytokines with the cells. So, so they said that it was a sandwich model in which the proteins were actually the breads, and the phospholipid bilayer was the jam. So, but however, later studies found problems with this model, particularly at the placement of the membrane proteins, which also had hydrophilic and hydrophobic regions. Because we know there are different amino acids, some are polar, some are non-polar. The non-polar ones will be hydrophobic, the polar ones will be hydrophilic. Okay, so uh, when scientists analyzed the amino acids of the proteins they thought to be on the surface or to be forming the upper and the two layers of the sandwich model, they said what happens to the hydrophobic regions then? They should be inside the layer, not at the surface. So in 1972, Singer and Nicholson proposed that the membrane was a mosaic of proteins that was dispersed within the phosphate bilayer. So now the phosphate bilayer became the bread, and the proteins, not necessarily the jam, but they could be either between the uh, layers of phospholipids, or they could be spanning the whole section, or they could be just on the surface, depending on the type of protein. Okay, so mosaic of proteins dispersed within the bilayer with only the hydrophilic regions exposed to water. The combined evidence of electron microscopy studies and the studies of chemical composition led to the development of the fluid mosaic model for the structure of biological membranes. Okay, so as we know, again, you have to keep a bit of thermodynamics in your mind. So we know that every molecule inside any kind of structure, let it be solid, fluid, liquid, or gas, has its own motion. It will keep moving. Okay, it has its own vibration, and it's also will keep moving. So on the basis of those, the fluid mosaic model was developed, and they used a particular type of experiment which is known as the freeze fracture study. So what we do in case of freeze fracture studies is you give something, you layer the cell surface with something, a very cold fluid, let's say nitrogen. Just layer liquid nitrogen, just layer it, and then with a microtome you try to take out a bit of, you just try to slice it. Okay, so what happens is the uh, outer surface of the cell membrane will get attached to the old whatever you have given, and then you're cutting it with the knife, so the extracellular layer gets stripped away from the cytoplasmic layer. So as you can see, very interestingly, the inside of the extracellular layer was like this, but the inside of the cytoplasmic layer was like this. Okay, so they're more granular, so a lot more proteins are there. The freeze fracture is a specialized preparation which splits the membrane along the middle of the phospholipid bilayer. So now we see that, as we saw from the freeze fracture pictures, now we can now see that the proteins were not equally dispersed along the lipid bilayer. Somewhere on the top, somewhere in between. The intracellular layer had a cytoplasmic side of the phospholipid bilayer had more proteins embedded in them. So, what are the types of membrane proteins? So, integral membrane proteins are very strongly associated with the hydrophobic core of the lipid bilayer. So, obviously, if it has to be inside the phospholipid bilayer, it has to be strongly hydrophobic, because that is the hydrophobic region. So, and peripheral membrane proteins are associated with the plasma membrane by electrostatic and hydrogen bonds with the polar groups of the lipids. Okay, so these are on the surface. So on the surface is, as I have mentioned before, that is the hydrophilic region. So that has to be, the bonding has to be electrostatic or hydrogen bonds. And amphitrophic proteins are found are both on the cytosol and the membrane. So these amphitrophic proteins will have bits and pieces of both hydrophobic regions and hydrophilic regions. Okay. So integral membrane proteins, let's read a bit more about them. So the form attachment of these proteins inside the lipid bilayer. is due to the hydrophobic interactions. And between the acyl chains of the lipids, acyl chains means the fatty acid chains, and the hydrophobic domains of the proteins. Okay, so and they have a single hydrophobic sequence in the middle. Glycophorin is one example of one such protein. I'll come to that a bit later. So they will have a hydrophobic sequence in the middle so that they can latch onto the hydrophobic regions of the lipid bilayer. So either it will be in the middle, or it will be in the amino terminal, or in the carboxy terminal. Okay. Others have multiple hydrophobic sequences, each of which, when in an alpha helical conformation, is long enough to span the lipid bilayer. So if you think back to the structures, the secondary structures of proteins, you will have alpha helix, beta sheet, beta barrel, all these things are there. So whenever a protein is there, it won't just lie in a straight line. So it will form some kind of conformation. It will take on some kind of conformation. So there are proteins which have multiple hydrophobic sequences. Uh, for example, just on the top of your mind should be the G protein coupled receptors. They have they have 7 transmembrane spanning uh, transmembrane spanning regions. So they have 7 hydrophobic sequences. That's why, and these are all in alpha helical conformation. So this is just like there are like two regions, two hydrophobic regions. As you can see, this is fully hydrophobic, while this one has a bit more polar amino acids. And this protein is actually the glycophorin uh, protein you find in RBC. Okay, so there are segment of 19 hydrophobic residues which form the alpha helix and which can traverse the middle hydrophobic region of the lipid bilayer. And the amino terminal and the carboxy terminal, they are mainly formed of your polar compounds, polar amino acids, which is why you get you are getting them, they are outside, so they are interacting with the water molecules. Okay, so bacteriorhodopsin, again I said, so it's a light driven proton pump which is in regular arrays with the packed in regular arrays in the purple membrane of the bacterium Halobacterium salinarium. So just an example, so as I said, there are 7 membrane spanning regions in GPCRs. This is corresponding protein in bacteria. So X-ray crystallography, scientists have done X-ray crystallography and revealed a 7 alpha helical segment is traversing the lipid bilayer connected by a non-helical loop at the inner and outer surface. So these 7 segments have around 20 hydrophobic amino acid residues, and each segment is just long enough to form an alpha helix that spans the bilayer. Okay. So they have different types. This integral protein sequence will have different types. So if they have only one transmembrane helix, so they'll be segregated into type 1 and type 2. So if the amino terminal is outside the cell, then it is type 1, and if it's inside the cell, it is type 2. Type 3 has multiple transmembrane helices. So glycophorin, if you can take it back, glycophorin amino terminal was outside the cell and it has only single hydrophobic region. Okay, so that is why it is type 1. Bacteriorhodopsin has multiple transmembrane helices, that's why it is type 3. So in type 4, there are various transmembrane domains from various polypeptides. So in one protein, there can be more than one polypeptide. So individually, these polypeptides will have different transmembrane domains. Okay. Type 5 is a protein where it is anchored to the membrane by covalently linked lipids. And type 6 are associated with membrane via both transmembrane helices and lipid anchors. So they will have both the hydrophobic regions and a connection to the lipid bilayer via a lipid anchor. So, how do we see the topography of the membrane proteins? Delineating the 3D structure of intrinsic membrane proteins are difficult because they will only form that particular structure in that particular condition. That is when they are inside the membrane. Some structures have been ascertained by nuclear magnetic resonance spectroscopy. However, the 3D structure may be predicted from the sequence of the amino acid from the peptide and hydropathy charts. So if you know the uh, amino acid sequence of the amino acid sequence of the protein, you can theoretically uh, design a model in which you can predict how the protein is situated in the lipid bilayer. Okay, so a region with more than 30 residues of high hydropathy index is assumed to be a transmembrane segment. So okay, so there is one term here, high hydropathy index. So again we have to travel back a bit to the thermodynamics that we have learned in class 11 and 12 to understand this. So what is a hydropathy index? So hydropathy index is nothing but the energy needed to bring that molecule to make that molecule travel from one end of the lipid bilayer to the other end. Okay, so let's say you have an amino acid A. You don't know whether that is a polar compound or a non-polar compound, and you are slowly bringing it through the cell membrane. Now if it's a polar compound, then it will cross the initial hurdle very easily, and but it won't be able to go into the hydrophobic regions. On the other hand, if it's a non-polar compound, then it will try to stay inside your lipid bilayer and you will not be able to take it out, which will lead to a higher hydropathy index. Okay, so this is a glycophorin pattern. As you see, there is only one region where the residues had a high hydropathy index, and as you can see here, the more the hydropathy index, more hydrophobic it is. And in case of bacteriorhodopsin, we have 7. Okay, so just what we have already learned before, that bacteriorhodopsin has 7 transmembranes. So actually, by seeing this hydropathy index charts, you can predict that okay, this protein will have a single domain, single transmembrane domain, or it will have 5 transmembrane domains, or it will have 7 transmembrane domains. Okay, so the transmembrane domains may either be alpha helices or beta barrels. Why not beta sheet? Because beta sheet does not maximize the interactions and are not generally found on the interior of the membrane. So favorable factors are no available water molecules for hydrogen bonding with the carbon and oxygen, and nitrogen of the peptide bond, and the maximal interchain hydrogen bonding. Okay, so beta sheet does not allow that. Beta barrel does allow that. That's why beta barrels and alpha helices are seen more. Another feature of the transmembrane protein is the presence of tryptophan and tyrosine molecules at the lipid aqueous interface. These act as membrane interface anchors. Okay. So anchoring of membrane proteins without transmembrane domains is achieved by covalent linkage with one or more lipids. However, the strength of hydrophobic interaction between the bilayer and a single hydrocarbon chained linked protein is barely enough. So only one linkage is not enough to hold on to it. So you need more. So what happens is the covalently linked lipid anchor membrane proteins, lipids anchor the membrane proteins to the bilayer. So a palmitoyl group is shown to be attached by thioester linkage to a cysteine residue. Myristoyl group is generally attached to the amino terminal glycine. So there are these particular combinations which have to be there for this kind of anchoring to happen. Okay. And the another kind of combination that we can generally see is the farnesyl and geranyl groups attached to the carboxy terminal cysteine residues. And these farnesyl and geranyl groups are actually 15 to 20 carbon fatty acids. Okay. So, and the other interactions such as the positively charged lysine residue with the negatively charged heads of the phospholipids also help stabilize the anchoring of the protein via the lipid anchors. So, just as I was saying, myristoyl with the myristoyl group will amino terminal glycine. This is how they will anchor. The palmitoyl group uh, will help anchor via bonding with cysteine, and the farnesyl group or geranyl group will anchor via the carboxyl terminal cysteine. Okay. So lipids and proteins are asymmetrically distributed, as I have already said. So this is a distinct functional symmetry. So even though it might look random, it is not totally a random distribution. So in the plasma membrane of the erythrocytes, containing phospholipids like phosphatidylcholine and sphingomyelin are typically found on the outer, that is extracellular leaflet, while phosphatidylserine, phosphatidylethanolaamide, and phosphatidylinositols are much more common in the inner cytoplasmic leaflet. When phosphatidylserine in plasma membrane moves to the outer leaflet, a platelet is able to play its role in formation of blood clot. So you also should remember that phosphatidylserine exposure on the outer surface is also a marker for apoptosis. Okay, so the whole arrangement, it might seem random, but it is not random. So one of the characteristics and properties of the plasma membrane is its flexibility in this composition without compromising the cellular function and the integrity of the plasma membrane. So this depends on the temperature and the types of lipids present in the bilayer. At lower temperature than lower than optimum temperature. So optimum temperature is around what our body temperature, that is around 98.6 degrees centigrade. Okay, so lower than this optimum temperature, the lipid bilayer is in the gel phase. The movement of the individual lipids are constrained. At relatively higher temperature, individual hydrocarbons of the fatty acids are in constant motion. So this is also fits into our thermodynamic, what I was saying. Then more the internal energy and thus the temperature, more will be your motion of the individual molecules. So so at relatively higher temperature, individual hydrocarbon chains of the fatty acids are in constant motion produced by rotation about the carbon-carbon bonds of the long acyl side chains. So this is known as the liquid disorder state or the fluid state. So relatively semi-solid gel phase, this is your gel, more ordered, and there's an intermediate liquid order state and a relatively high temperature liquid disorder state or the fluid state. Okay. However, we do not see such drastic changes in the fluidity of biological membranes because different types of lipids are present and their distribution is regulated by the cell to prevent any kind of loss of integrity. So long chain fatty acids, saturated fatty acids such as the oleic acid and stearic acid pack well into the liquid ordered array, but the kinks in the unsaturated fatty acid interfere with the packing. So If you remember the first phospholipid I had shown you, one was a saturated, the other one was the unsaturated acid. So the unsaturated acid was bending away. So that kink or that bend interferes with the packing and favors the liquid disordered state. So in case of your temperature falling a bit, the cell will try to insert more unsaturated fatty acids so that the fluidity of the cell membrane remains the same. Conversely, if the temperature is getting too high, within obviously within physiological limits, then it will try to insert more saturated fatty acids or cholesterol moieties, which will reduce the fluidity. Okay, so effect of sterolysis reduces the fluidity in the core of the bilayer, thus favoring the liquid ordered phase and increasing the thickness of the lipid leaflet. So now let's come to movement of lipids. Lipid molecules in biological membranes show flip and flop and lateral diffusion. The lateral diffusion is obviously very rapid; it will just keep moving. However, the bilayer flip flop diffusion of lipids is very slow unless it is catalyzed by specific proteins. So this is because you need to move that polar head group to leave its aqueous environment, and you have to move it through the hydrophobic inner layer. A process which needs a large positive free energy change. So, uh, so this kind of flipping of the phospholipids from inner to outer or vice versa actually needs therefore a catalyzing protein. So, so there are three different types of catalyzing proteins: flippase, which moves the phosphatidylethanol and phosphatidylserine from outer to cytosolic leaflet; flopase, which will move phospholipids from cytosolic to outer; and scramblase, which moves lipids in either direction depending on the equilibrium. So the first two need ATP, the third does not. Now let's come to how we came to know that a lateral diffusion is happening. So first, what the scientists did is they added a fluorescent probe. So this is like a molecule which will emit light when excited. And this fluorescent probes will go and bind to the lipid layer. It will only bind to the lipids. Then an intense laser is put on the cell to bleach a certain area. So in that area, all the fluorescent probes are, let's say, destroyed. Actually, bleaching is something else. Bleaching, the fluorescence is over. Like it reaches a steady state. It will not show any more fluorescence. But for now, let's say those in that area, your fluorescent probes are destroyed. But if you still keep the cell under the microscope, after some time, you will see that uh, some amount of fluorescent probes you can see in that bleached area, which means lipid molecules which still had the fluorescent probe attached to their head have moved into that area. Okay, so that is how we knew lateral diffusion of lipids is happening, and this is how we measure the lateral diffusion rates. And this technique is known as fluorescent recovery after photobleaching, or FRAP. So a similar kind of technique using a single fluorescently labeled lipid molecule was seen uh, to see exactly how much it is traversing and how exactly it is traversing the cell membrane. Okay, so this is known as Hop diffusion because it was seen that for some time within a certain region of the cell membrane, the lipid will keep going and then it will hop to a different region. And again, after some time, it will hop to a different region and again to a different region. So why does it need to hop? So so the answer is the proteins are actually forming these leaky barricades in the cell membrane. To cross those barricades, the lipid molecule will have to find a particular space through which it can leak through. Okay, so when it's managing to leak through, it is hopping off to a different region of the cell membrane. So while protein also shows similar lateral diffusion, sometimes they form a patch of membrane which is rich in a particular type of polypeptide. In such patches, the proteins are immobile with respect to each other. The outer membrane proteins are anchored to the uh, internal structure and cytoskeleton that prevent the free diffusion. So, for example, glycophorin in RBC is anchored to spectrin and ankyrin. Okay, so this whole spectrin ankyrin thing you'll probably be reading in physiology and also probably in pathology in second year. Uh, but this is how most proteins are. They are linked to the microtubules or to other proteins inside the cell, which make them relatively static compared to the lipid molecules. So but there are some spaces inside the cell membrane where it is thicker. It has a certain kind of lipids. It will have. Just excuse me 1 second. Yeah, sorry. So there will be regions which are thicker, which are more stable. They will show lesser movement of both the lipids and the proteins. So these are known as the rafts. So rafts are regions where there is a long saturated acyl groups of sphingolipids along with the more amount of cholesterol. So these lipids help form microdomains which are more ordered, thicker, and enriched in two classes of integral proteins. So the two classes of integral proteins which are enriched are the anchored integral proteins and the covalently attached long chain membrane proteins which are covalently attached to long chain saturated fatty acids. Okay. So here you see an example. So more cholesterol, as I've already said, it will create a thicker and more stable cell membrane. And in here you will get these proteins which are GPI anchored, or they will have fatty acyl anchors. Okay. So specific type of cell membrane receptors and signaling proteins are seen to aggregate together in the membrane rafts, and which therefore maximize the chance of interactions of different two proteins. So one of the proteins which is very important in this kind of rafts is the caveolin. So integral membrane proteins with two globular domains, which is connected by a hairpin-shaped hydrophobic domain, which binds the protein to the cytoplasmic leaflet of the plasma membrane. Three palmitoyl groups are attached to the carboxy terminal globular domain and further anchors it to the membrane. Here, if you see, so there is a hairpin shaped loop which is inside, and there are acyl groups helping the caveolin to be anchored. So this presence forces the associated lipid layer to curve a bit inwards to form little caves or caveoli in the surface of the cell. Okay, so these kind of proteins, when they are present, they will help in curving the uh, plasma membrane, leading to a formation of this kind of claviola. So this is important because it will be through this claviola you will have exocytosis, endocytosis, and in case of budding of vesicles from Golgi complex, that will also happen through uh, the action of such proteins. Viral infections will also happen. The whole pinocytosis, phagocytosis, everything happens through this. Fusion of sperm with the oocyte, that also with the egg will also happen. So that is why clavioline is a very important protein for cellular function. So uh, like clavulin protein will help in curvature, but what helps in fusion of two cell membranes? So there's a vesicle and this is a plasma membrane. How will the two fuse? So first there needs to be a local increase of curvature of the membrane. So, and secondly, they will need to recognize each other. There should be markers on both the membranes so that they recognize each other, and then their surface will become opposed. Their bilayer structures will have to be locally disrupted, and consequently, they will fuse to form a continuous bilayer. And this has to be triggered at a particular time because you can't have this happen randomly. Okay, so there are different proteins which can help in the curvature. Clavulin was one of them. There are other proteins which are intrinsically curved, so when they are associated with the cell membrane, they will curve that region of cell membrane will also curve, allowing both the membrane and protein to achieve their lowest energy. There are other proteins which are not which in multimeric form, in monomeric form, do not cause bends, but if they aggregate, they will form a superstructure which favors and maintains the curvature. Okay, and then there are other proteins which amphipathic helices inserted in one leaflet of the bilayer and crowds the lipids in the leaflets, forcing the membrane to bend. So now I'll give just two short examples of uh, fusion, membrane fusion. So one of the important ones is the hemagglutinin protein, which helps a viral virus to fuse with the cell. This is of course very important right now because COVID is going on, and if you have read a bit, it enters the cell through the ACE2 receptor. So that is not exactly what is happening here, but just an example to make you understand what is the importance of the studying these kind of things. Okay, why you need to know. So what happens is virus binds to the sialic acid receptor on the host surface, and this triggers an endocytosis. Okay, so the membrane will bend inwards, and what happens is a virus, when a cell is trying to endocytose a viral particle, it will try to also kill the viral particle. So you will get lysosomes which will come and join the endocytic vesicle. So when in the endocytic vesicle, so what happens? The pH drops, and and at normal pH, the hemagglutinin proteins has the fusion parts or the domains which will help in the fusion. Those domains are buried, but when the lysosomes attach and the pH falls, these fusion proteins, as you can see, they will extend and insert into the endosomal membrane. So what happens after this is there is a contraction of the protein. The protein structure changes, pulling the two membranes close by and forming hairpins and drawing the viral. So the hemagglutinin will fold into hairpins, drawing the viral and endosomal membranes together. Okay, so and this will lead to a local disruption. So at this level, there will be a local disruption, and hemifusion will occur first with the outer monolayer of the virus fusing with the inner monolayer of the endosome. Consequently, complete fusion will occur, in which, because of this end, I'll just mark it here. So this is not a thermodynamically favorable position for the lipid bilayer to be in. So that is why even this will break and form the lipid bilayer. So now what do we see? That there is a complete fusion leading to uh, and so all the viral particles that was inside here, okay, or here, can now just come out and enter the cell and start the viral replication process. Okay, so one more example, uh, what happens at the synapse, neuronal synapse, how we get a uh, release, how the neurotransmitter is released at the synapse. So the secretory vesicle or the cytosolic vesicle will have a kind of protein which is known as the V snare, while the target membrane, target plasma membrane will have two proteins known as the T snare and the SNAP25. Now V snare and T snare recognize each other and they will bind, forming a zip-like structure which will draw the two plasma membranes together, and SNAP25 will stabilize this zipping. And when you're pushing them together and there is also a zipping action, this will lead to a lateral tension of the bilayers favoring the hemifusion, as we saw previously, between the outer leaflets, causing a formation of an energetically unfavorable void. So just as I said back there, so here is the void. So, and this void will again thermodynamically force the inner inner leaflets of both the membranes to break and fuse. Okay, and so once this has happened, now the pore will widen and the secretory vesicle can release its stuff inside the cell, and the complexes, protein complexes, move away from each other. Okay, so the importance in this case is botulinum toxin or the Botox, what you use, is actually acting on this complex. So it actually binds and prevents the formation of this zipping structure. That is how Botox works. So I hope this was an interesting example, and I hope you have a little bit of more interest in cell biology post this lecture. And have a good day and goodbye.
Good afternoon, everyone. So today, for this class, the topic will be hormones, their mechanism of action. Now, Starling in the year 1905 coined the term hormone to describe secretin, which was a substance secreted by the small intestine into the bloodstream to stimulate pancreatic secretion. He then defined hormone as substances released from ductless or endocrine glands directly to the blood. The hormone is synthesized by one type of cells and transported through blood to act on another type of cells as defined by Vasudevan. Now, before going to the details of the mechanism of action of hormones, we do need to understand the concept of second messenger or signal transduction. Now, if we consider a cell where a reaction needs to be carried out, and suppose A needs to be converted to B, we know that there are lots of biochemical reactions that goes on inside the cell. Then maybe to carry out the reaction A to B, a messenger can come from outside the cell. It can cross the cell barrier, cell membrane, go inside and directly help in the reaction to happen. Alternatively, the second approach is there may be receptors within the cell membrane, and the messenger, which is the first messenger, binds to the receptor, and that binding to the receptor triggers a reaction which leads to the generation of another messenger, which carries out another reaction, leading to formation of a new product that carries out another reaction, leading to formation of a new product, which finally carries out the reaction A to B. So the difference between the first type of transduction and the second type of transduction, the conveying of the message, the main difference is in the second type, we have got a multiple or we have got a many types of regulatory approaches. The cell has got multiple checkpoints, regulation points through which it can have a control over that reaction to happen or not to happen. So this type of transduction of a signal where the messenger binds to the receptor leading to the generation of another one, another messenger, and that leads to generation of another one is known as second messenger. And this is the signal transduction theory. So with the background of the second messenger and the signal transduction theory, now we come to look into the classification of hormones. Hormones are majorly classified into two groups, 1 and 2, where the group 1 indicates the hormones that bind with cell surface receptors. Under that cell surface receptors, you have 1A, 1B, 1C, 1D, and 1E. So the 1A group is the hormone which mediates its function via the second messenger cyclic AMP, which is also known as CAMP. Examples of these hormones include ACTH, ADH, FSH, HCG, LH, TSH, MSH. There are so many. Glucagon. One Example you need to remember, I would suggest it should be glucagon, because we'll be looking into the details of the mechanism of this type of hormones, especially with reference to the mechanism of action of glucagon. 1B is the group of hormones which act via second messenger cyclic GMP, like atrial natriuretic factor, NO. 1C is the group of hormones which act via second messenger calcium or phosphoinositol uh, phosphate, PIP2. Examples include TRH, GnRH, vasopressin, oxytocin. 1D is the group which mediates its action via tyrosine kinase. And the classical example of this group includes insulin. 1E is the group which mediates via kinases, or it may utilize phosphate cascade. Examples include adiponectin, leptin, resistin, growth hormones. So, all these five categories of hormones have one thing in common. All these hormones, they bind with cell surface receptors and they mediate their action through some second messenger. There is another category of hormone which binds to intracellular receptors. Examples include glucocorticoid, mineralocorticoid, sex hormones, thyroid hormone. And the major difference between this group 2 hormone with group 1 is group 1 hormones, they bind to receptors located within cell surface. Whereas group 2 hormones, they have the ability to cross the cell membrane, they have the ability to go inside the cell, and they can bind to intracellular receptors, following which the action is mediated. So we'll be going into the details of the mechanism of action of these hormones. So we'll be starting off with 1A. But before that, to understand the mechanism of action of these hormones, we need to know another concept. We need to know another protein, which is known as G protein. The G proteins are intracellular signaling proteins that are named for their ability to bind to guanosine triphosphate. They also possess GTPase activity. These G proteins, they bind to GTP, and what happens when they bind to GTP? They hydrolyze GTP, guanosine triphosphate, to guanosine diphosphate, since they have a GTPase activity. Now, there are heterotrimeric G proteins and there are RAS superfamily G proteins. Heterotrimeric G proteins have three subunits: alpha, beta, and gamma. They use G protein linked receptors. They regulate second messengers. The RAS superfamily G proteins are monomers. They resemble alpha subunit of heterotrimeric G proteins and they are catalytic. They use catalytic receptors. So the basic difference between heterotrimeric G protein and RAS superfamily G protein is the number of subunits. In heterotrimeric, you have three subunits, alpha, beta, gamma, whereas in RAS superfamily, you just have one, alpha. So the hormone or neurotransmitter is the first messenger. It binds to the receptor. This receptor is linked to the G protein having three subunits, alpha, beta, gamma. That G protein is linked to another enzyme which is regulated by this G protein. Upon the binding of the hormone, there is conformational change in the receptor which changes the G protein in a way so that it gets activated. And when G protein is activated, it activates the enzyme. That enzyme being activated carries out the reaction which it is supposed to carry out. And in this way, the signal relay happens via regulation of second messenger production. And ultimately, you get the biological response of cell. The receptor which we are talking about, so the receptor to which the hormone binds, it is also known as G protein coupled receptor, GPCR. The GPCR receptors, they have an extracellular domain that contains the binding site for a ligand, which may be a hormone or neurotransmitter. They have an intracellular domain that interacts with G proteins and 7 transmembrane helices. So the class 1A is the hormones that act via CMP. The first step is hormone binding. Second, activation of G protein. Third, signal transduction via cyclic AMP. And fourth, the intracellular effect. So the hormone binds to G protein coupled receptor in the cell membrane, leading to the activation of G protein. The activated G protein induces the production of cyclic AMP by adenylyl cyclase. Cyclic AMP further activates protein kinase A for further signal relay, and the intracellular effect is achieved by phosphorylating proteins responsible for cellular functions. An occupied receptor does not interact with GS protein. In this case, see what happens. There is no hormone attached to the receptor. The receptor it is in its normal state, and the G protein, the alpha, beta, gamma subunits is attached with a GDP, and especially the GDP is attached to the alpha subunit, and the adenylyl cyclase is inactive. But when the hormone binds, as I told in the previous slide, it undergoes a conformational change, like the receptor to which the hormone binds, that GPCR, G protein coupled receptor, it undergoes a conformational change and interacts with the GS protein. So this is the GS protein, uh, which has the three subunits alpha, beta, gamma. But what happens is, due to the interaction of the receptor bonded to the hormone with the G protein, there is a change in the uh, alpha subunit, and it releases the GDP and binds GTP. And when GTP is there instead of GDP, the entire G protein gets, activated. So the alpha subunit of the GS protein, it dissociates from the beta and gamma subunit, and it activates the adenylyl cyclase, which then converts ATP to cyclic AMP plus pyrophosphate. When hormone is no longer present, the receptor reverts to resting state. The GTP on the alpha subunit is hydrolyzed to GDP, and adenylyl cyclase is inactivated. So the same thing, let us see in an animated form. If you consider this to be the cell membrane, this is your G protein coupled receptor. The G protein in the normal state with the alpha, beta, gamma subunit and a GDP attached to the alpha subunit, and the E indicates the inactive adenylyl cyclase enzyme. So the next step is hormone. The first messenger comes and binds to the receptor, leading to a conformational change, as a result of which a GTP gets attached to the G alpha and the GTP is replaced. Since now there is GTP instead of GDP with the alpha subunit, the alpha subunit dissociates from beta and gamma along with the GTP, goes and interacts with the enzyme and in turn activates it. The activated adenylyl cyclase enzyme will now produce cyclic AMP from ATP. And we just saw how the second messenger cyclic AMP is generated due to the action of the hormone. Now, when the hormone binding is no longer there, so the hormone has been released, the receptor comes to its native conformation, the GTP is replaced again by GDP, and the alpha subunit along with GDP comes back to the beta gamma subunit, and the enzyme again returns to the inactive state. So we have seen how cyclic AMP is produced. Now, what does cyclic AMP do? So when cyclic AMP is produced, there's a particular enzyme inside the cell known as protein kinase A. This enzyme has got two regulatory and two catalytic unit. The cyclic AMP, four of these cyclic AMP molecules binds to the regulatory units of the protein kinase A, and the binding of CAMP with the regulatory unit dissociates the catalytic unit, and this catalytic unit now catalyzes the phosphorylation of enzymes. So proteins gets converted to phosphorylated protein, which gives to intracellular effects. Now, when these intracellular effects are no longer needed, what happens? There are alternative sets of enzymes, protein phosphatases, which dephosphorylate the phosphorylated protein to form the dephosphorylated protein. So that exactly completes the mechanism of action of group 1A hormone, which act via the second messenger cyclic AMP. If we want to see this thing, apply this knowledge with the help of a real hormone, so let us do it in a interesting form. Let us consider that there is a hormone. Now, you all know this, that whatever I'm talking now, you have already read about this probably in some other chapters. I'm just giving you, I'm just introducing you a hormone. There is a hormone which activates protein kinase just by the way I just mentioned, illustrated right now. This protein kinase, in turn, what it does, it converts the glycogen phosphorylase enzyme into phosphorylated glycogen phosphorylase. Also, it converts glycogen synthase enzyme to phosphorylated glycogen synthase. Now, if we see, glycogen phosphorylase is an enzyme which is responsible for glycogenolysis. In dephosphorylated state, it is less active, but when phosphorylated, it is active. Alternatively, glycogen synthase is an enzyme which helps in glycogen synthesis. It is active in dephosphorylated state, and upon phosphorylation, it becomes less active. So, this hormone, under the presence of this hormone, these two enzymes are phosphorylated so that glycogen phosphorylase is now active, glycogen synthase is less active. What does it indicate? Which metabolic pathway is this hormone triggering? It is triggering glycogenolysis. It is triggering glycogenolysis. And who does that? Glycogenolysis, which is the release of glucose in the blood. Who does that? Glycogen synthesis, which is storing of glucose in the blood, and we are talking about glucagon. So, when we saw the classification of hormones, we looked into the list of the hormones mentioned under group 1A, and we saw glucagon to be there. So, it is glucagon, which is a type 1A hormone, and it is responsible, or it acts via cyclic AMP. So definitely the second messenger is cyclic AMP, and it activates protein kinase A, and this protein kinase will phosphorylate enzymes. So it phosphorylates two key enzymes responsible for two key metabolic pathways: glycogen phosphorylase, glycogen synthase. Glycogen synthase, which is normally active in dephosphorylated state, becomes less active when phosphorylated. So that is how glucagon uh, inhibits the glycogen synthesis. On the other hand, glycogen phosphorylase, which is inactive in dephosphorylated state, becomes active when phosphorylated, and that is why and that is how glucagon stimulates glycogenolysis. Now we come to class 1b. If you have understood class 1a, class 1b is no different. It's the same thing. The mechanism is exactly the same. The only difference is, instead of production of cyclic AMP, here you are producing cyclic GMP. So the same thing again, the activation of guanyl cyclase is done by several compounds like nitric oxide. So this activation leads to production of cGMP, guanyl cyclase, like adenyl cyclase was producing CAMP from ATP, guanyl cyclase is producing cGMP from GTP. The signal transduction is happening via cGMP. cGMP activates dependent protein kinase G for further signal relay. It is also involved in visual cycle, and there is an intracellular effect, uh, which is by phosphorylating proteins that regulate calcium dependent contraction and motility, leading to relaxation of muscles and vasodilatation. The extracellular calcium concentration is 5. So we are done with group 1A and group 1B. Now we are coming to group 1C. So the 1C is the category of hormones which mediate through calcium and PIP2. So before we go to see how these hormones act, let us just have a brief idea about calcium and some interesting facts about calcium. So the first interesting fact is the concentration of extracellular calcium is roughly 5 millimole per liter. On the other hand, the concentration of calcium within the cell, intracellular, is 0.05 to 10 micromole per liter. Can you appreciate the strong difference in the concentration? One we are talking in millimole, the other we are talking in micromole. So it's 1,000 times difference even in the units only. So in spite of this large concentration gradient and a favorable transmembrane electrical gradient, calcium is restrained from entering the cell. Prolonged elevation of calcium in the cell is very, very toxic. A sodium calcium exchange mechanism pumps calcium out of cells. A calcium proton ATPase dependent pump extrudes calcium in exchange for hydrogen, the proton. And calcium ATPases pump calcium from the cytosol to the lumen of the ER. So these are the three mechanisms by which cell maintains very low level of calcium. As we saw that prolonged elevation of calcium is very, very toxic for the cell. So the cell has three mechanisms. Sodium calcium exchange, it pumps calcium out of the cell. Calcium proton ATPase dependent pump, which extrudes calcium in exchange for H plus. And calcium ATPases pump, ATPases, they pump the calcium from cytosol to the lumen of the ER. Now, to understand the mechanism of this group of hormone, we also need to know some facts about another protein. Just like it was G protein in case of 1B and 1A group of hormones, it is calmodulin, a 17 kilodalton weighted protein, which is homologous to the muscle protein troponin C in structure as well as function. It has got 4 calcium binding sites. And when these sites are fully occupied, it leads to a marked conformational change, which allows calmodulin to activate enzymes and ion channels. So calcium calmodulin regulates the activity of many structural elements in cells, like enzyme activity, ion transport, endocytosis, mitosis, granule release, cell motility, all these things. So calmodulin along with calcium is the main way through which this group 1C hormones act. So if you want to see it in a illustrated way, again the first part remains the same. Hormone binds to specific receptor. Here the G protein, the subset of G protein is a bit different. It is GQ. So the occupied receptor interacts with GQ protein. Again, the same thing. There is an alpha, beta, and gamma. So the GTP is replacing. So the initial GDP is gone. The GTP has replaced the GDP, and then the alpha subunit of GQ dissociates from beta and gamma and activates the phospholipase C. And this activated phospholipase C cleaves PIP2, phosphatidyl inositol 4,5 biphosphate, to inositol triphosphate, IP3, and DAG, diacylglycerol. So adenylyl cyclase was producing cyclic AMP, guanylyl cyclase was producing cyclic GMP. Here we are dealing with phospholipase C, which is cleaving phospholipase C enzyme. It is cleaving PIP2 to IP3 and DAG. Now this IP3, it has the capacity to bind to a specific receptor on the ER, endoplasmic reticulum. And the binding of IP3 to endoplasmic reticulum, it causes the release of sequestered calcium. And this particular calcium, which is now coming from endoplasmic reticulum, will in turn, along with diacylglycerol, activate the protein kinase C. Protein kinase C will now phosphorylate proteins, and this phosphorylation will lead to the intracellular effects, just like we saw in group 1A and group 1B. So if we look into the action of group 1C through calcium or PIP2, the endoplasmic reticulum is the storehouse of calcium. So when stimulated, just the way we saw it in the last slide, calcium will come out from the endoplasmic reticulum. We read earlier that calmodulin is a protein which is homologous to the troponin C protein in structure and function, and it has got 4 binding sites for calcium. So 4 molecules will bind to calmodulin, and this calcium calmodulin complex will convert an inactive enzyme to an active enzyme, which will carry out the enzymatic conversion of substrate to product. Now we come to group 1D hormones. And this one is very, very important because one key classical hormone, insulin, is the member of this category. So these are hormones which act through tyrosine kinase. And if we want to simplify the understanding, of the mechanism of these hormones, so we can have 3 basic steps. Recognition. The recognition is hyperglycemia, because I'm talking about insulin. I'm talking specifically about insulin here. So due to hyperglycemia, which acts as a recognition signal, the insulin uh, binds to tyrosine kinase. Now, tyrosine kinase is again the receptor which is having 2 alpha subunit, 2 beta subunit, and the binding of the insulin molecule to tyrosine kinase leads to something known as autophosphorylation. So tyrosine kinase has got inherent component, phosphorylating component, and what it does is when it gets attached to insulin, it autophosphorylates itself. And when it autophosphorylates itself, that leads to the second step of the process, which is the signal generation. Phosphorylated tyrosine kinase will further activate a protein called IRS. There are 4 different kinds of IRS: IRS 1, 2, 3, 4. So phosphorylated tyrosine kinase will in turn phosphorylate IRS, which activates PI3 kinase. And then there follows a number of sub-molecules like PKB, SGK, APKC, P70S6K, mammalian target of rapamycin, mTOR. All these sub-signal transaction and sub-molecules lead to the effect of increasing glucose transporter in the cell, increasing insulin receptor in the cell, increasing the IGF-2 receptor in the cell, increasing protein phosphatases, increasing phosphodiesterases, decreasing the transcription of enzymes like PepsiK, phosphoenol pyruvate carboxykinase, increasing the transcription of enzymes like hexokinase, glucokinase, etc. Further, the IRS, the insulin receptor substrate, is also responsible to carry out another signal transduction with a different set of molecule. These molecules include GRB2, MSOS, RAS, RAF, MEC, MAPK, a very complicated set of transduction which finally leads to the cellular function of increased cell growth and DNA synthesis. So this is a kind of generalized mechanism of insulin where we are seeing, we are linking insulin with its physiological properties by showing or by going into the details of the biochemical steps involved within its mechanism. The group 1E hormones are the hormones which act on cytokine receptor. This include like growth hormone, prolactin, erythropoietin, cytokines, all this. Now, the group 1E hormone, they uh, they utilizes kinases, and one such kinases is known as JAK, Janus kinase. It's a kinase, but it has got a name Janus to it. And this Janus is a Greek god. And the characteristic of this Janus is it has got two heads in opposite direction. And why this kinase is known as Janus kinase? We'll see that in the next image. Anyways, the basic mechanism of action is ligand binding with receptor, activation of cytoplasmic kinases like JAK that I mentioned, Janus kinase, activation of STAT by phosphorylation. So just like Janus kinase, we have a protein, another protein, STAT. So that is why this pathway is also known as JAK-STAT pathway. STAT is signal transducer and activator of transcription. So STAT dimerizes and translocates into the nucleus. And finally, the transcription is activated by binding to a specific DNA element. So now if you can see the picture of JAK, you will be able to appreciate that it has got two heads. So that is why it is known as Janus kinase. So here we can see a cytokine getting attached to the Janus kinase receptor. Isolatedly they are present, but on binding to the cytokine, the two subunits, the beta 1 and beta 2, they come close, and obviously just like tyrosine kinase, they also get phosphorylated. Phosphorylated JAK activates STAT, so STAT comes and binds to the phosphorylated JAK, producing JAK-STAT complex, and this phosphorylated STAT now dimerizes. Once dimerized, this phosphorylated dimerized STAT goes inside the nucleus, binds to specific DNA elements to activate the transcription of DNA. The hormones with intracellular receptors, the group 2 hormone, is a totally different story. So by this time, we have finished group 1. Quick revision. Group 1 is the hormone that act via cell surface receptor. We have seen that there are 5 subcategories in the group 1 hormone: 1A, 1B, C, D, and E. This subnomenclature is basically due to the difference in the second messenger that these hormones use. Group 1A hormone uses cyclic AMP as the second messenger. Classical example, glucagon, important for your exam as a long question. Explain the mechanism of action of glucagon. Group 1B uses cyclic GMP, important as short note. Group 1C uses calcium, uh, phospholipase C, TIP2. Again, short notes, calcium calmodulin complex is important. Group 1D, that acts via tyrosine kinase. Classical example, insulin. Long question, mechanism of action of insulin, or compare and contrast the mechanism of action of insulin and glucagon. Explain why insulin and glucagon are different in their mechanism of action, antagonistic in their nature. These kind of things you can expect as a question. Group 1E, which is a very short one, but again, the JAK-STAT pathway is getting very importance in recent times due to their association in several with several diseases. So JAK-STAT pathway becomes important. What is JAK? What is STAT? And obviously, these all small topics can be sources of good MCQs for your exam. So now we come to the group 2 hormone, the hormones that act with intracellular receptors. So mainly these hormones are the steroid hormones, and they have got two different kinds of signaling. One, classical signaling, which is also known as nuclear initiated steroid signaling. Two is MIS, which is membrane initiated steroid signaling. Now, the steroid receptors are of various types, type 1, type 2, and they are just different on the basis of which type of hormones do they interact with. On that basis, they are different. So if we look into the graphical presentation of the mechanism of action of hormones mediating their function with intracellular receptors, then the basic thing is here, hormone has the ability to cross the cell membrane. It goes inside the cell. It will obviously bind to a receptor, but that receptor is either located in the cell or it may be located inside the nucleus. So it may be a location of this receptor, maybe in the cytoplasm. It can also be in the nucleus. And the hormone receptor complex, either it forms in the cytoplasm or it forms in the nucleus. Wherever it gets formed, it binds to the enhancer region, which has a hormone response element, HRE. Now, this enhancer region or the hormone response elements containing regions are the regions which, when when this hormone receptor complex binds to this region, what happens? They activate the gene promoter, leading to the start or activation of transcription. So when hormone is there, hormone receptor complex is there. When hormone receptor complex is there, these hormone receptor complex is binding to the enhancer region. And when they are binding to the enhancer region, what is happening is that the transcription is activated and you are getting more transcribed product, more mRNA product of your uh, particular protein. So in this way, these hormones, they activate transcription, thereby they are regulating gene expression and they are increasing the number of proteins in the cell. So if we do the thing about the same in a theoretical way, we can subdivide the entire mechanism of action into these major points. So the first step is diffusion of hormone through plasma membrane, leading to its binding to intracellular receptor, which either can be in cytoplasm or it can be in nucleus. The next step is formation of hormone receptor complex, in which the translocation to nucleus will be if the hormone receptor is in the cytoplasm, because hormone receptor complex, as I mentioned, it can be produced in cytoplasm And if it is produced in cytoplasm, it needs to go to nucleus, or it can directly get produced inside the nucleus. Within the nucleus, the hormone receptor binds to the hormone response element, which is an enhancer region, and then it dimerizes. And this leads to an increase in the transcriptional activity via the activation of promoter region. And that leads to the induction of protein synthesis, more mRNA generation, transcription followed by translation. So you are getting more proteins. So that sums up the knowledge for today's class, hormones mechanism of action. We'll just go back once to the through the entire slides, a quick revision of what we learned. So we started off with the definition of hormone, that they are substances released from ductlets or endocrine glands, which are directly they are secreted into the blood, and they are synthesized. They have been defined by Dr. Vasudevan in his textbook as they are synthesized by one type of cells transported through blood to act on another type of cells. We understood what is second messenger, what is signal transduction, what is the difference, and what is the advantage of having a second messenger or a signal transduction system. It gives us more control over the metabolic pathway. It gives the cell a more control over the metabolic pathway. Correct? Then we came across the classification of hormones. We looked into the chart and we found out, or we read, that hormones can be of two types. The first one is the type which binds with cell surface receptor. The second type is the hormone that binds to intracellular receptor. Just to give you a note here, this classification can be reversed in some books, and it is actually reversed in some books. So don't get confused. Follow anyone, the science remains the same. In some books, they have categorized group A, B. Some books, they have done group 1 as the hormone that binds to intracellular receptor, and group 2 as the hormone that binds with cell surface receptor. There is no fixed thing in it. It's just that forget 1 and 2. There are two categories. One category of hormone which binds with cell surface receptors, under which there are five subcategories because of the five different second messenger system. That is cyclic AMP, cyclic GMP, calcium PIP2, tyrosine kinase, other kinases or phosphate cascade, and there is another category of hormone that binds to intracellular receptors. We came to know what is G protein. They were intracellular signaling proteins that are named for their ability to bind to a GTP. Since these protein bind GTP, they are called G protein. They also possess a GTPase activity. So proteins that can bind to GTP, not only it can bind to GTP, but also it can break GTP to produce GDP. G proteins can be of two major types, heterotrimeric and Ras superfamily G proteins. There are three subunits of heterotrimeric G protein, alpha, beta, gamma. The Ras superfamily G proteins are monomers. So that was the basic difference. And this was the basic outline of how the total mechanism takes place within the cell. We also looked into the GPCR, which has got seven transmembrane domains or helices. So this is also very important uh, MCQ for your exam, this GPCR, and definitely a very common question in AIIMS MCQ is how many transmembrane helices does a GPCR have? So the answer is 7. It's also known as serpentine receptor because it looks like a snake. So the class A hormones had four basic steps: binding of hormone, activation of G protein, signal transduction via cyclic MP, and finally the intracellular effect due to phosphorylation of proteins. We saw in various ways, we tried to understand the mechanism of this group of hormones, how G proteins gets activated, how the entire thing is carried out within the cell, that hormone binds with the receptor, leading to a conformational change, and this conformational change leads to the replacement of GDP by GTP in G protein, and the G alpha GTP complex gets dissociated and it binds to adenylyl cyclase. and then it activates adenylyl cyclase, which produces cyclic AMP. And when the hormone is no longer attached to the receptor goes back into its native conformation. The G alpha, which has the GTPase activity, breaks down GTP. Again, GDP comes in, and this G alpha GDP now comes back and joins beta gamma subunit, and the adenylyl cyclase becomes inactivated again. And these cyclic MP molecules, they can bind to the regulatory unit of protein kinase A, which leads to the dissociation of the catalytic unit from the regulatory unit. And this thing, what it does, it makes phosphorylation. So it phosphorylates protein. It phosphorylates protein, leading to intracellular effects. And when this phosphorylation is like when the function is not more required, it's no more required, then the cell has alternative protein phosphatases which dephosphorylates the protein to stop the function going on. Example, there was a hormone which stimulates protein kinase, and in turn it phosphorylates glycogen phosphorylase and glycogen synthase in a way that glycogenolysis is promoted and glycogen synthesis is inhibited, and that hormone was glucagon. Class 1b hormones, again the same thing, the only difference is in case of adenylyl cyclase, here we have guanyl cyclase. In case of CAMP, here we are producing CGMP, and the signal transduction is happening through CGMP inside the cell. Group 1C, we came to know about calcium. It's interesting fact that there is a big concentration gradient of calcium intracellular versus extracellular, and how and why this gradient needs to be maintained. We came to know about calmodulin, which is a protein homologous to muscle protein troponin C. It has got 4 calcium binding sites, and calcium calmodulin complex regulates the activity of many structural elements in the cell. We look into the mechanism of action of group 1C proteins. Again, same thing, only the subset of G protein is different, GQ, and instead of adenylyl cyclase, now here it is phospholipase C, which leads to production of IP3 and DAG. IP3 releases calcium from endoplasmic reticulum. Calcium along with DAG activates protein kinase C, which further leads to intracellular effects. And similarly, we also saw how the calcium, which is released from endoplasmic reticulum, binds to calmodulin, 4 binding sites, and this in turn converts an inactive enzyme to an activated enzyme. Group 1D is the action through tyrosine kinase. We outlined the total mechanism into 3 sections: recognition, which is hyperglycemia; insulin, binding to tyrosine kinase, and leading to autophosphorylation of tyrosine kinase, which further leads to a signal generation where insulin receptor substrate IRS 1, 2, 3, 4, they are further phosphorylated, and they initiates a series of signal transduction reaction involving a series of or a battery of molecules, which finally leads to the intracellular effects that include increased glucose transporter insulin receptor, IGF-2 receptor, increased protein phosphatases, phosphodiesterases, decreased peptic A hexokinase increased, as well as glucokinase increased. Further, through another battery of molecules, it increases the cell growth and DNA synthesis. Finally, there was group 1E hormone, which was acting on cytokine receptor, the Janus kinase thing, the JAK-STAT pathway. The basic outline is the same. The only difference is the components which are involved are different. In insulin, it was tyrosine kinase. Here it is Janus kinase. And then JAK-STAT. STAT is another protein. So there is a combination of JAK-STAT, which we saw in this picture, that upon binding of the ligand, there is autophosphorylation of Janus kinase, which leads to the binding of STAT, phosphorylation of STAT, dimerization of STAT, and that dimerized STAT is increasing the gene expression. Finally, we came to group 2 hormones, which were the intracellular receptor group, which acts through intracellular receptors. We saw that these hormones, they first bind to the receptor after crossing the cell membrane. Receptor can either be in the cytoplasm or it can be in the nucleus. Wherever it is, the hormone receptor complex is formed and it binds to the enhancer region and gets dimerized. Due to this action, there is promotion of the transcription, and transcription followed by translation. So, overall, the protein synthesis is induced by these hormones. So, thank you everyone for the class. Uh, Thank you so much.